All right, everyone, welcome. We're going to do a high-yield masterclass on pediatric anthropometry. Look, whether you're grinding for your boards or just want to sharpen your everyday clinical skills, mastering these measurements is absolutely non-negotiable. So let's dive right in. And, this quote really says it all, doesn't it? Before you even think about complex labs or fancy imaging, the simple act of measuring a child's growth, that is the absolute cornerstone of pediatric health. It is our most powerful, most accessible tool for figuring out how a child is really doing.
So, here's how we're going to break it down in this explainer. First, we'll lay the foundation, why this stuff matters so much. Then we'll go through the toolkit, the core measurements you have to know. After that, we'll get into technique, which is all about charts and accuracy. And finally, we'll put it all together and talk about interpretation, turning those numbers into a real diagnosis.
Okay, let's start with our foundation. This is not just about plotting some dots on a chart. It's about understanding why this skill is one of the most fundamental things we do in pediatrics. Think about it. Anthropometry is this amazing all-in-one screening tool. With just a few simple, non-invasive measurements, we get a snapshot of a child's overall health, their nutrition, their whole developmental journey. A weird pattern on that chart, that could be the very first clue that something's off, whether it's a medical issue or even a social problem at home. It truly is a gold standard. So, here's the crucial point. If you remember only one thing from this section, make it this. It's about the pattern, not the single point. One measurement in isolation can totally fool you. Maybe the kid just had a stomach bug. The real story, the data that actually means something, comes from accurate measurements taken over and over again over time. That's where we find the truth.
Okay, on to our second section, the toolkit. These are the core measurements you've got to know inside and out. No question about it, for your boards and for your clinic. First up are linear measurements. For the little ones, infants and toddlers under 2, we measure recumbent length. They're lying down, and we use an infantometer. Simple enough. Once a child can stand up straight and reliably, usually right around age 2, we switch over to measuring standing height with a stadiometer. It's a basic distinction, but a super important one. Next is weight. This is our most sensitive marker for any acute changes in a child's nutritional status. And the key here, the real key is using the right tool for the job. A properly calibrated infant scale for the babies and a floor scale for the bigger kids. Always make sure they're accurate. Now, head circumference. We do this routinely for kids under 2, and it's basically a stand-in for brain growth. An abnormal measurement, either too big or too small, can be one of the earliest signs of a major neurodevelopmental problem. So you can see why getting this measurement right is so critical. And then, of course, there's BMI, or body mass index. This isn't a direct measurement. It's a calculation. You take the weight in kilograms and divide it by the height in meters squared. The American Academy of Pediatrics recommends we use this to screen for adiposity, that's excess body fat, in all kids starting at age 2. Okay, for your boards, this is a huge takeaway. The AAP's 2023 obesity guidelines are all in on using BMI. And just to back that up, a recent study from June 2024 in the journal Pediatrics confirmed yet again that a high BMI is a really solid screening tool for finding kids with too much body fat. So yeah, it has its limits, but for our purposes, you can be confident it's a useful clinical tool.
Okay, on to section 3. So we know what to measure, but how we measure it and which charts we use, well, that's where the rubber really meets the road. Precision is everything here. Let's start with a classic boards question. You've got a healthy, exclusively breastfed baby in front of you. Which growth charts are you going to use for their first 2 years? What's the right standard? Just think about it for a sec.
And the answer is the WHO charts. This is the perfect way to understand the difference. The WHO charts are a prescriptive standard. They show us how healthy breastfed babies should grow under the best conditions. Think of it as the international goal for kids from birth to 5. The CDC charts, on the other hand, are a descriptive reference. They just show us how a mix of kids in the US with all sorts of feeding did grow in the past. So for that healthy breastfed baby, it's WHO all the way.
Now, let's talk technique. To get a good, accurate recumbent length, look, it is a 2-person job, period. You need one person to hold the baby's head steady against the headboard looking straight up, and a second person to gently straighten out the legs and bring the footboard up flat against the heels. If you try to do this by yourself, you're just asking for an inaccurate reading. Head circumference is another one where mistakes happen all the time. First, you have to use a non-stretchable tape. Then you position it just above the eyebrows and the ears, and you make sure you get it around the widest part of the back of the head. Pull it snug to press down the hair, and here's the kicker for boards and for best practice, you do it twice, and you record the average of the two closest readings.
And this brings us to what is easily the biggest clinical pitfall of all. It's not some rare genetic disorder. It's just plain old measurement error. Using a wonky scale, having sloppy technique, or just rushing, it can lead to bad data, which leads to unnecessary stress and workups, or even worse, missing a real problem. Standardize your technique. Use good equipment every single time.
All right, let's bring it all home with our final section, interpretation. This is where we take all that accurate data we collected and turn it into something that actually helps our patients. So, what are the big red flags we're looking for on that growth chart? Well, the number one thing is a sharp turn up or down away from a curve the child was already following. A flat line is never normal. The classic textbook answer, crossing two major percentile lines, is definitely a concern, but honestly, by the time that happens, it's often a late sign. And you also want to watch for big disconnects, like a kid whose weight is at the 10th percentile, but their height is way up at the 90th. Now, this slide right here, this is pure high-yield board review gold. You just have to memorize these cutoffs. Wasted is a weight for length or BMI below the 3rd percentile. Stunted is a length for age below the 3rd percentile. And for BMI, overweight is above the 85th, and obese is above the 97th. Seriously, know this table cold. Here is a huge clinical pearl, one you'll use all the time. For premature infants, you always have to use their corrected age when you plot them on the growth charts. That means you take their actual age and subtract the weeks they were premature. And you keep doing that until they're at least 24 months old, sometimes even up to 36 months. It's the only way to get a true picture of their catch-up growth.
But please, remember this, and it's so important for being a safe clinician. These charts, these cutoffs, they're screening tools. They are not a diagnosis by themselves. They just tell you, hey, you need to look closer. You always have to put these numbers into the context of the whole kid, their family history, their exam, everything.
So let's end with this question to kind of frame your thinking. Your patient is doing great, growing perfectly along the 50th percentile. So what do you talk about with the parents? The answer is that even perfectly normal growth is a chance for us to do our job. It's an opportunity for positive reinforcement, to praise what the family is doing right, and to give that anticipatory guidance that builds a foundation for a healthy future. That, right there, is the art of pediatrics.